Well, thank you very much for that very kind introduction. So, as you all know, there are many different dialyzers we can now buy for our patients. The question is, why should we choose one particular type of dialyzer compared to another dialyzer? So, in the next slide, if we think about dialyzers, one of the issues that goes through our minds would be the clearance. We're thinking about the surface area of the dialyzer, the pore sizes, the composition, the chemical composition of the polymer, and the hydraulic permeability. How permeable is the dialyzer to movement of water? And then hemocompatibility, the smoothness of the surface. Has there been any modification of the surface? And then as blood goes across the dialyzer, what is the inflammatory reaction in terms of generating free radicals, and also in terms of the risk of clotting of the dialyzer? Now, in the next slide, if we think about clearance, traditionally we thought about the clearance of a small molecule urea. And the original of the so-called K2V concept comes from this study performed in the US many, many years ago in the 1970s. This was a very short-term study of 12 months and showed that patients who had higher levels of blood urea came out of the study, they dropped out of the study quicker than those that had lower levels. But this study was not designed to look at whether clearance of urea affected patient survival. But in the next slide, in this study, the HEMO study, again in North America, in the US, looked at what happened if there was a higher target of urea clearance. And what you can see from this is that by simply trying to achieve a higher target of urea clearance, there was no benefit in terms of patient survival. So what next? And in the next slide, some years later, the investigators of the HEMO study looked back at their data and found that if they looked at the serum beta-2 microglobulin levels, you can see that those patients that had the highest serum 2 beta microglobulin levels had the worst outcome. They had the worst survival. And this suggested that perhaps removing larger molecules might be of an advantage in terms of improving patient outcomes. And so in the next slide, this comes from a German study, the 4D study. And you can see here in terms of, this was a longer study in terms of patient follow-up. And they looked at the difference of different types of dialyzers: low flux cellulose, low flux semi-synthetic, low flux synthetic, and high flux synthetic. And you can see there's almost a stepwise increase in patient survival, moving from low flux cellulose to high flux synthetic dialyzers. And so in the next slide, the question, of course, is what's the main difference between low flux and high flux? Well, simply what they've done is increased the removal of these so-called middle-sized molecules by moving the curve from the left to the right, but still below that of the glomerular basement membrane in terms of sieving. And so in the next slide, if we think about what we want for a dialyzer membrane, we want a membrane that has pores, that allows the removal of small molecules like urea, but also allows the movement of larger molecules, say, such as beta-2 microglobulin. But we don't want the pores big enough to allow loss of albumin or other key important proteins. Equally, we don't want endotoxin or other contaminants in the dialysate to be able to pass through the pores back into the patient's bloodstream. So the question is, well, can we design or redesign membranes that give us better quality in terms of removing larger size molecules, but without removing albumin? So in the next slide, we have this concept of developing so-called middle cutoff membranes. So why the term middle cutoff? And that's because the first generation of these type of membranes were called high cutoff. And the problem with the high cutoff membranes is they unfortunately cause losses of albumin. So therefore, these membranes had to be altered to reduce these very large pores. And so we have this generation of so-called middle cutoff dialyzers. And you can see here, here's the difference between a high flux dialyzer in blue and the orange color of the middle cutoff membrane. So we get an increased loss of so-called middle molecules in this range. And in the next slide, the question arises, well, does it really matter what type of dialyzer is used in terms of the polymer composition? Now, this data comes from Taiwan. It's over 70,000 patients, but it's been collected over a number of different years. So there are some issues in terms of how we can actually interpret this data. So it looked from this data that patients who are dialyzing with what's called an EVAL or ethylene vinyl alcohol dialyzer seem to have the worst outcomes, followed by cellulose triacetate. But as you can see, only less than 1% of patients in this study actually dialyzed with this dialyzer. So there are some issues in terms of confounding as to how to interpret these results. However, in the next slide, even if we have a membrane that's made with the same polymer, and in this case polysulfone, from the same manufacturer, you can see that even a membrane made from the same substance can actually have different functions in terms of allowing different spectrum of molecules to be lost or cleared during dialysis. So it's actually quite a complex issue in terms of the flux of the membrane, in terms of the pore size of the membrane, and in terms of the composition of the membrane, in terms of how these membranes actually operate in clinical practice, in terms of their ability to remove middle molecules. So in the next slide, this gives you an idea of this symposium. So we're going to have a talk about dialysis choice and patient survival. We're going to have a talk about clinically relevant outcomes. Talk about the comparison of one of these middle cutoff dialyzers and hemodiafiltration. So two treatments designed to achieve improved middle molecule clearance. And then a talk about the differences again in terms of the modality and in terms of differences in membranes. So in the next slide, if you remember, I showed you this picture of lots of different types of dialyzers. So hopefully by the end of the talks today, you'll have some ideas as to what type of dialyzer to use for different types of patients.